Okay, so here we go. You know, one of the main reasons why we're presenting this information, providing this training to staff, is because we know that smoking and tobacco use harms a lot of people. It's very deadly. It's the leading cause of preventable death and disability in the United States, in Texas, and in the world. And when we look at it every year, over 480,000 people are dying from tobacco-related illness or from a smoking-related illness. And this doesn't include the people that are dying from smokeless spit tobacco deaths, people that are dying from secondhand smoke exposure. If we calculate all those deaths in there as well, we're far and above 500,000 deaths each and every year related to a tobacco-related illness. When we do look at the causes of death, as you can see on this graphic, lung cancer is the #1 cause of death, followed very closely by heart disease, and then chronic obstructive pulmonary disease, which could range from people having emphysema to chronic bronchitis to asthma, kind of all run along that spectrum for chronic obstructive pulmonary disease, or COPD, it's also called. And when we look at strokes as a singular cause of death, almost 15,000 people die from strokes each and every year. And one thing when we talk about lung cancer, it's really interesting, excuse me, that 90% of all lung cancers are linked directly back to smoking. And so if we were able to eliminate the smoking in our society, we'd be able to eliminate about 90% of all lung cancers in our society and be saving about 130,000 lives each and every year just by reducing lung cancer deaths. And when we start looking at the people that we're serving, people with mental illness or substance use diagnosis, we do know that it's shortening their lifespan anywhere from about 5 to 10 to 25 years, shortened lifespan. So it's really in the best interest for us to be helping our clients and the people that we're serving to quit using tobacco products. So like I said, lung cancer is a leading cause of death, followed by heart disease. And on this graphic, it shows a number of the different chronic diseases that are either caused by or made worse by smoking, and number of cancers. Lung cancer isn't the only cancer caused by smoking. There's 15 different cancers that have been directly linked causally to cigarette smoking. We're not going to go through each of these cancers, but just so that you know that there are a number of different cancers linked back to smoking. And as far as chronic diseases, there's many chronic diseases that are caused by smoking. And the Surgeon General's report that came out in, I believe it was 2010, stated that no organ is immune to the adverse effects of cigarette smoking. And as you can see from this very long list of chronic diseases, how much smoking is impacting our body. One thing that we'd like to talk about and point out are folks who have diabetes. Smoking does cause diabetes in the first place, and it makes it very hard to manage and control a person's diabetes if they're using cigarettes. And what that could look like is their blood sugar levels go up and down, very hard to control their blood sugar levels. Their insulin, if they're using insulin, they'll have to take a stronger or a higher dose of insulin because the tobacco smoke actually slows down the absorption rate of the insulin. So they have to take a higher dose of insulin to get the same effect. We also see that people with diabetes and are smoking cigarettes are at greater risk of amputation of their feet and toes and lower extremities because of further reduction of blood flow to their feet and extremities. And we also see a greater risk of blindness and macular degeneration because of further reduced blood flow to their eyes. So it's really important that as we're working with people that we know that have diabetes, to encouraging them to quit smoking to help them better manage their diabetes. Oops. And once we start looking at some of the co-occurrence of substance use and mental health disorders and tobacco use, we see a very, very strong prevalence in smoking amongst people um, uh, who among this population that are using cigarettes. I'm sorry, I'm trying to get my, there we go, to minimize that. So even though individuals with non-nicotine substance use disorders or mental health disorders represent 25% of the people in the United States, so relatively small percentage of the population, they account for 40% of all cigarettes consumed in the United States. So we have about a quarter of the people smoking almost half of all the cigarettes in the United States. So they're smoking a tremendous number of cigarettes. And as a result of that, smoking a lot of cigarettes, they're also incurring a lot of the health consequences and financial consequences. As you can see here, about $39 billion each and every year being spent to purchase cigarettes by people with a mental health or a substance use disorder. And what we're kind of looking at here as far as the number of people that are smoking, we see that about 8.2 million people in the United States have co-occurring disorder of substance use disorder or a mental health disorder. And when we look at the smoking rates among people with serious mental illness, and this does not include people that have a substance use disorder. This is folks with depression, schizophrenia, bipolar disorder, primarily as their primary diagnosis. And what this graph is showing on the top line there is the smoking rate for people with serious mental illness. And the bottom line represents people that have no mental health diagnosis. And as you can see, we've seen some steady decrease and with both populations. What's really striking is that we have smoking rate is over twice as high for people with a mental health diagnosis than people without a mental health diagnosis. And that stayed very, very persistent over the past decade that we've been keeping track of this. Even though we are making progress, we're still not narrowing that gap between people with serious mental illness and people with no mental illness. Now, when we factor in the smoking rates for people with a substance use disorder, very, very high smoking rates, between 70 to almost 90% of adults are smoking cigarettes from a couple different studies here. Individuals with alcohol dependency are 3 times more likely to smoke, and folks with a drug dependency are 4 times more likely to smoke than the general population. And we see some really, really strong associations in interaction between opioid use and tranquilizers and nicotine use. We see this very, very prominently with the opioid centers that we are working with, where they report about 92 to 95% of their clients are also smoking cigarettes. Some of the reasons why we see these strong associations, a lot of it has to do with coping with pain, either trying to reduce the pain that they're experiencing or distracting themselves from the pain. Some of it has to do with boredom, maybe being bound, homebound, not being able to interact with people as regular as they would like, the frustration and anger and just some of the anxiety and depression that might come along with that addiction or along with some of that pain that they're experiencing. And then also to just generate some positive feelings and some positive reinforcements, some enjoyment from smoking. So there's a lot of different reasons. And as we talk with people about quitting smoking, kind of exploring, investigating what are some of those reasons? Why are they smoking? Why are they using their tobacco products? And how do they perceive that helping them manage with pain, other emotions, or other things going on in their lives? To kind of transition and look at tobacco use products amongst high school students here, we see that electronic cigarettes are by far and away the most common form of nicotine consumption by young people now. and I was just at a convenience store filling up with gas, and there was a brand new electronic cigarette product out called Glass, G-L-A-S. Brand new. I've never heard of it, and they were selling the little pods for 99 cents a piece, and the device is really inexpensive. It was $5.99 for the device. So it's getting really, really down there for price point. I've never heard of this product. I just saw it on a gas pump when I was filling up with gas this morning. So all kinds of new products coming out for all these different electronic cigarettes, and where we have anywhere from 20%, I would probably say up to about 25%, and maybe even higher in some school districts of young people using electronic cigarettes. The combustible cigarettes, you know, that's really kind of the shame. We were getting down in that single digit range for young people using combustible cigarettes, and then the electronic cigarettes really came onto the scene and filled that void. And now we've seen that incredible spike of electronic cigarette use. As far as combustible cigarettes, though, we still have about 8% of folks using combustible cigarettes, and a very high percentage of young people are using cigars. And this could be categorized as maybe the little cigars, the little cigarillos, like the sweet and mild cigars, things like that. The main reason I think why we see such a high rate of smoking or of use of cigars, because a lot of these products are flavored. You know, you can buy flavored cigars, small cigars, things like that. You can't buy a flavored cigarette except for a menthol cigarette. So I think that's where we see that very strong attraction to cigars. Smokeless tobacco or spit tobacco, I'm sure this range is a very wide range. So might see a much higher rate of spit tobacco use out in West Texas region rather than maybe Laredo or here in Austin or even in Houston. So that's probably a very regional a rate of what young people are doing. And then hookahs and pipe tobacco kind of round out the end there. And so we bring this up just so you have an awareness and an understanding of what type of products young people are using. And so as you're having conversations at your centers with adolescents and young adults, having these conversations and not assuming that they're only using cigarettes, that they may be using multiple products, and that cigarettes probably aren't the primary product that they're using. It might be an electronic cigarette, or even a cigar or a small cigar or spit tobacco.
Bryce?
Yes, ma'am.
Just a question on that.
Mm-hmm.
On the electronic cigarettes, at what age can they buy them? Can they purchase them?
Very, very good question. And so in Texas, well, across the entire nation, actually, the law is 21 years old. But in Texas, as I say that, for military personnel, you only have to be 18 years old to purchase it. So, and that's not only on Army bases or Air Force bases. Well, you know, they could go into a convenience store and present their military ID. And if they're over the age of 18, they can purchase that product. So that's one of the kind of carve outs in the Texas law, is that any military member over the age of 18 can purchase tobacco products, but non-military young people, they have to be over the age of 21 to purchase the products. Very good question. And to kind of follow that up, a question that we also, there's some confusion. So folks think, well, that also applies to nicotine replacement therapy, and it doesn't. So anyone over the age of 18, regardless if they're a military member or not, can go to CVS or Target or Walgreens or Walmart, wherever they want to go. As long as they're over the age of 18, they can purchase over-the-counter nicotine replacement products. So the nicotine patches, nicotine gum, and nicotine lozenges. So any other questions or follow-up or clarification you'd like on that? That was a good question. All right. All right. Um, so with individuals with intellectual and developmental disabilities, and so I think that Kat works in this area with these folks out in West Texas Center. And so this is really kind of new, like I said in the previous training. Very, very limited data. Really, the data that we have here comes from some research out from New Jersey with a psychiatrist, Dr. Jill Williams, out there. So there's really no curriculums or programs developed to help these folks. Quit using tobacco products can be very, very individualized and a lot of trial and error, and maybe extending the process out significantly to help people with an intellectual and developmental disability quit using tobacco products. So kind of like what we see in the general public, we see that men are more likely to smoke or to use tobacco than women. And that individuals with intellectual and developmental disabilities and comorbid substance use disorders have a lifetime tobacco use estimates of up to 83%. So there's once again that very, very strong connection between substance use disorders and tobacco use. They kind of just go hand in hand for everybody, unfortunately. Individuals with mild to moderate intellectual disabilities have higher smoking rates than those with more severe intellectual disabilities. And this is probably something that you'll see this trend as you start talking with people, if you haven't noticed this already, at some of your centers. And this one really kind of breaks my heart, that even though they're more likely to see a doctor more often, they're not as likely to receive tobacco screenings or interventions or encouraged to quit using tobacco products, or even have that conversation brought up by their doctor. So they're really missing out on a lot of opportunities to present these interventions to the people that they're serving. And that's really where we come in. The doctors, we know that the doctors may not be doing that. So we can step in and kind of fill that gap and have these conversations with the individual and the caretakers that are helping them. And the other thing that we see are individuals living in group home settings are generally smoke more, 20%, than people living with a family member or significant other or friends, where it's down to about 3 to 5%. So where they're living impacts their smoking rates. And once again, many times we have staff that are living in those facilities or working in those facilities at those group environments. And so once again, we have the opportunity to have some really meaningful interventions with everybody at those facilities. So here are some treatment modifications kind of that are a little bit different out of the norm of how we might treat people without an intellectual and developmental disability. One thing that we would do for everybody is to enlist a significant other or family members or a support system, and to express concern about that smoking and listen to their fears about quitting. So bringing all these folks in and having them talk to the person about their tobacco use, but also hear what some of their concerns are and just enlisting their help. Identifying the roles that they can take in helping that person make a quit attempt, and how can they be supportive through that process. I think a lot of times people try to help people quit smoking, and sometimes that can be a detriment. What people consider being helpful, actually not very helpful. They might be nagging people, they might be shaming them or blaming them, putting guilt trips on them to quit smoking, things like that. And that actually pushes people further away from making a quit attempt. And so coaching and helping the significant others or the caretakers to be a positive role model or a positive influence in someone making a quit attempt might be needed also. And instead of them being maybe an obstacle or a barrier to someone successfully quitting smoking. Be certain that any materials are understandable to the client, and using repetition to reinforce those skills. Redefining terms in the language that we typically use. like I use tobacco dependence or nicotine dependent. That's probably not going to fly using that language. Withdrawals, urges, cravings, all of those words, we're going to have to use different language and words when we're working with uh, um, people with intellectual and developmental disabilities. Being aware of the length of counseling time that the person can tolerate, and extending out as a result of that, probably gonna have to do this many, many times. So additional counseling sessions, and having a moving quit date, or maybe not even having a quit date, and having them cutting down cigarettes very, very slowly and in a very structured way, or even in an unstructured way. Um, Allowing time at the end of each counseling session to reinforce concepts and to talk about and identify what kind of stood out for them, and kind of developing maybe little plans or take homes or homework of what they're going to do maybe in between today and the next time we meet, maybe Friday or something like that, and what can they do to make some very, very small changes in their tobacco use. um, Another kind of a special population we talk about are people experiencing homelessness. And we see a very, very high smoking rate among people experiencing homelessness. I think this also is in conjunction with a very high co-occurring rate of mental health concerns and substance use concerns also. Once again, going very, very uh, uh, close hand in hand with one another there. Spending an awful lot of money on tobacco products, and many of the people that we serve have very limited and fixed incomes, but especially when we're working with people that are experiencing homelessness, where they might be panhandling some money and they make $30 or $40 a day, getting money on a street corner or from people giving them money. And then they go buy a $7 pack of Newport cigarettes, and that's a third of their money right there, just on one pack of cigarettes. Or they're buying one cigarette for $1 or one cigarette for 50 cents, and they smoke 4 or 5 of those, 6, 7 of those a day. And right there's $7 that they've spent on 7 cigarettes. So really impacting them financially, as well as their health and their mental health. We do know that they're targeted by the tobacco industry. We might not see this out in Big Spring and some of the more rural communities, but we definitely see that here in Austin, and probably in Laredo and some of the more urban areas. We're here in Austin, it's not a surprise that there's 3 tobacco shops surrounding our homeless shelter, on each of the streets kind of surrounding our homeless shelter. It's not a surprise. And the different types of products that they're advertising there and the price discounts that they're providing at these shops is much, much different than anywhere else that we see throughout the city of Austin. And a lot of our festivals that we have here in Austin, when we have ACL and South by Southwest and different things like that taking place, the tobacco industry is out there giving away shirts and hats and products and things like that. There's some limitations what they can do now because some regulations, but they're still out there exploiting some of the loopholes in those laws and regulations. Like I said earlier, they're more likely to experience substance use and mental health concerns. And when we look at a study in Oklahoma, not only are they smoking a number of, smoking cigarettes at a high rate, but they're using pretty much anything they can get their hands on. They might be rolling their own cigarettes. They might be using electronic cigarettes. They might be smoking cigars. They might be using spit tobacco. It's kind of a lot of multi-tobacco use products within this population also, which was kind of interesting. I didn't really expect to see that. And, with this one study that's highlighted here, and I think Dr. Lorraine Reitzel on our team participated in this study and did some of that research up in Oklahoma City. When we also look at GLBT community as a subpopulation, very, very high smoking rates, disproportionately high smoking rates. about 20.5% of LGBT adults are smoking compared to 15.4%. When we look at some gay or lesbian, it kind of stays the same right there. When bisexual, a little bit higher compared to heterosexual men and women. So a little bit different, very, very high rates among women, much higher rates among women than a straight man or straight women. So with that, so why do we see such high smoking rates amongst all these different populations? A lot of it has to do with lower income. We know that that's a big driver in a lot of health disparities, lack of access to health insurance, healthcare, going to the doctor, preventative resources, and then just access to resources to quit. And even if they are going to the doctor, maybe the doctors, their primary care providers, not asking them about their tobacco use and encouraging them to use their tobacco use. And like we said earlier, they're often directly marketed by the tobacco industry, and we won't talk about that later. That was in the big one. The chronic stress and ineffective coping skills and coping mechanism that they're using, and cigarettes, one of those ways of dealing with stress and coping with life situations, which is kind of a maladaptive coping skill, as a person that I trained once called it, which I thought was kind of an interesting phrase. Environmental exposure and peer groups. You know, when you have anywhere from 30 to 40 to 80 or 90% of your peers, the people that you associate with on a daily basis, you see them smoking cigarettes, it becomes a very, very normative and accepted behavior. And you kind of think, well, everybody is smoking because that's who you associate with and that's who you're hanging out with. And maybe even when you start looking at family history, maybe family members have smoked all the way through their life, and very, very few people have actually quit smoking. And so it's just kind of one thing that it's normal for people to smoke. So that environmental exposure and peer groups plays a big, big role in that. And then along with that, that kind of plays into the lack of social support systems, especially maybe from family, friends, and where helping professionals like ourselves, we might be one of the strongest support systems that people have. And so they might lean on us quite a bit to help them quit, but then we also have to help them branch out and identify other supports. If that's a quit line, if that's an online resource, if that's a supportive family member or some other program in the community that can help them. We'll talk about some of these widespread misperceptions and myths in a couple slides, but that really carries a lot of weight to why we see such high smoking rates. And then the perceived benefits of tobacco use on stress and anxiety, and we'll talk about that in a couple slides as well. So here are some of the myths and facts and some of those misperceptions. The belief is that people with substance use disorder and behavioral health conditions, that they don't want to quit smoking, they're unable to quit smoking, and that if they do quit, it's going to jeopardize their recovery, their mental health recovery or their substance use recovery. And what we know, that these are not true. We know that people with a substance use disorder and a behavioral health condition, that they're just as motivated to quit as people without these conditions. Anywhere from about 60 to 75% of people express an interest in wanting to quit smoking or have tried to quit smoking on their own in the past year, for both people with substance use disorders or not. They are able to quit. And what we see as we start having these conversations, that people have made many, many, many quit attempts. And what they're trying to do, they have that desire and that motivation to quit, but they haven't been using evidence-based treatments and effective ways to give them a good shot at quitting. You know, they're trying to quit cold turkey. They're trying to change brands. They're trying to change products. They're using electronic cigarette, and the list goes on and on and on of what they're trying. But one, they're not soliciting help. And then number two, they're not using a nicotine replacement therapy or some other medications to help them and give them a better chance of being successful. And then we also know, and I think we addressed this on the next slide, that quitting smoking actually enhances and substance use recovery and decreases negative mental health symptoms. So these are some of the benefits of quitting smoking. So when we look at tobacco use and substance use recovery, we see a 25% increased likelihood of long-term abstinence when people do quit smoking, which completely flips a lot of those beliefs on end. We're thinking that quitting smoking is going to make them relapse, which is definitely not true. And even if someone doesn't want to quit using alcohol or quit using some other drugs, by reducing and quitting smoking, we see a decrease in consumption of alcohol. So maybe there's a harm reduction strategy where someone wants to just cut back on their alcohol use. Quitting smoking will help them do that. And then, like we said, decrease relapse and increase past year abstinence. And Dr. Jill Williams out of Rutgers University found in 2005, which was one of the first studies, that continued tobacco use can actually harm recovery and be a very strong trigger for relapse. And when we start looking at that co-occurrence or just the association of smoking a cigarette and drinking alcohol, whenever I'm drinking, I'm smoking. Whenever I'm shooting heroin, or if I'm using methamphetamine, I'm always smoking a cigarette. Or, and all those rituals that kind of come along with those associations and those ties. So helping them. And we also see, especially with opioid use, that nicotine is kind of a brain primer. So that if someone is getting nicotine in their brain from smoking a cigarette, it's much harder for them to quit using their opioid medication. The withdrawals are much more severe, and the medications that they might be using also aren't effective too. So really important that people quit smoking at the same time that they're getting clean and sober. So any thoughts or questions about this one? This is one that we get a lot of pushback from folks on when we're giving presentations, when we're giving training. So any thoughts or comments on this slide? All right. Rugby and Isabel, if there's anything in the chat, jump in, because I have my screen kind of closed down to that. So if anyone puts something in the chat, please let me know and kind of stop me here.
You're good, Bryce.
All right, wonderful. And so here's what I was kind of talking about with tobacco dependence and opioid treatment outcomes. Treatment outcomes for smokers, we see an increased opioid withdrawal, we see increased cravings and lower detox completion, and methadone tapering. Just doesn't work very well to help people quit using their opioids while they're still smoking. Clinicians mistakenly believe that smoking has positive psychological functions, using it as a coping strategy, reinforce the coping through addiction and perceived stress reduction. And then, like I've said a couple times, it's positively related to opioid and cocaine abstinence when people do quit smoking. And we also see mental health improvements when people quit smoking, and this doesn't happen overnight. It might take a couple, maybe 2 or 3 weeks before people experience this decrease in anxiety, depression, and stress. And one thing as we're helping people quit smoking, we might want to prepare them that they might experience a slight elevation in anxiety and stress, and maybe feel a little bit depressed that first week or so when they do quit smoking. Quitting smoking is a tremendous lifestyle change. It completely turns people's life and their lifestyle and just everything that they do inside out and upside down. And as a result of that, there is a lot of anxiety, there is a lot of stress. And some people do feel a little bit more depressed. And it's not uncommon for people to say, it feels like I kind of broke up with my best friend, and my best friend left my life. Those are comments we hear a lot from former smokers or people that are going through that quit process. So kind of expect that and just prepare folks for that, but let them know that after a couple weeks, things are going to get a lot better, and they're going to see some of these decreases and increase in psychological quality of life and positive effect. We just see their mood kind of elevate. We just see this kind of cloud start to dissipate about them, and they just start kind of feeling better emotionally and physically, feeling better. And the very interesting findings in this 2014 research by Taylor and her colleagues was that the associated improvements of quitting smoking were greater than or equal to the effects of prescribing antidepressant medications for depressive and anxiety disorders. And that's a very profound finding, and that really goes to show how impactful quitting smoking is. But as I say that, I'm not saying we should stop prescribing medications to help people with depressive or anxiety disorders. Let's continue to prescribe those medications, and we're going to see these positive changes take place naturally when they quit smoking, which is going to make the medications work a little bit better. And because they're eliminating the tobacco smoke more times than not, they're probably going to need a lower dose of their medications, which might reduce some of the side effects of the medications, and the medication is going to work better. So it's really a win-win-win situation for the people that we're working with, to have them quit using tobacco products to see some further improvement in their mental health symptoms. Any thoughts or questions about this slide? All right, we'll keep on rolling here. So some barriers to intervention. So why are we not making some of these interventions and having these conversations with people? First and foremost, a lot of our staff, we lack necessary training and knowledge about cessation treatments. Myself, as an example, when I was doing substance use counseling in my undergraduate degree in my graduate program, I was specifically trained not to help people quit smoking when they're getting clean and sober. At the treatment center I worked with, we encouraged people to continue to smoke and not to stop smoking while they're in treatment. Because we don't have this knowledge and this training and all this kind of miscommunication or misinformation, it really reduced our confidence in our ability to deliver these treatments. Should we even deliver these treatments? Just getting past that one question is a big obstacle for a lot of folks. And so just providing some accurate information and some effective training for folks goes a long way. There's a concern that people will leave treatment, that they'll stop coming in for care. We don't necessarily see that in significant numbers with people. If we have conversation, especially if we just have a conversation with them about quitting smoking, they're going to give us an honest answer whether or not they want to quit or not. And even within our field and our profession, there's this permissive culture that allows smoking, and that's kind of an expected behavior, that smoking's okay, and that smoking helps with symptoms. And not only do clients report that, but also staff who might believe that it's actually helping them. And then we're making some rationalization that they're under a lot of stress, and that if we take cigarettes away, we're taking away that one thing that's helping them. And then we don't want to police tobacco use, and we don't want to be the one that tell them what they should or shouldn't do, which to an extent, we don't want to be telling people what they should and shouldn't be doing, but it's absolutely within our realm of services to encourage people to make some changes and advise them to quit using tobacco products. So when we kind of look at what does this conversation look like, these are the 5 A's. So first and foremost, we want to ask people about their tobacco use. So do you use tobacco products? And using that inclusive language of saying, do you use any tobacco products? And probably want to add in, or any electronic nicotine delivery systems or electronic cigarettes, something like that. So that we're getting a wide range of products that they might be using. We don't want to say, do you smoke cigarettes? Because we're missing a lot of different products if we limit it just specifically to cigarettes. All right, we're gonna take a little puppy break here and get the puppy out of here. So sorry about this. She was pretty asleep at my feet. So then the next thing we want to do is we want to assess people for their readiness to quit, their desire to quit, you know, and the great question to ask with that one is, do you have a desire to quit smoking in the next 30 days? And based on that answer, if they say, no, I don't want to quit, I'm not ready right now, you know, it's just not a good time to quit, we want to advise them to quit. And that advisement can be really related to whatever might be going on in their life. So I understand you don't want to quit right now, but quitting smoking is one of the best things you can do to improve your mental health and your physical health. You know, quitting smoking can increase the likelihood that of up to 25% that you'll remain abstinent, you know, with quitting drinking or using drugs. Whatever might be going on, if they have diabetes, quitting smoking can help you manage your diabetes a little bit better and more effectively. So that's what we want that advisement to look like, just very clear and concise message to them about how quitting smoking is going to help them in their life. If they'd say, yes, they do want to quit, then we assist them with that quit attempt, let them know what resources are available, how we can be a resource to help them through that process. And then whatever they choose to do to make a quit attempt, arranging that follow-up care to check in on them. How are they doing? Do they need more medication? Are they having some side effects or withdrawal symptoms or cravings? Did they relapse? Have they been successful and things are going really, really well? So arranging that follow-up is very, very important. And so now we'll kind of transition. We'll talk about nicotine replacement therapy real quick. So nicotine replacement therapy, how it works, it helps relieve the physical withdrawal symptoms. So when someone quits using their tobacco product, they go through nicotine withdrawal. Nicotine leaves our body relatively quickly. And so we start getting irritable, we get anxious, we get grumpy, we get maybe sweating, hands might shake a little bit. Those are the physical withdrawal symptoms that people experience when they haven't had a cigarette or a tobacco product for a little while. Their body is just withdrawing from nicotine. So by using a nicotine replacement product, we're relieving those symptoms by giving them, yes. And so we're addressing that physiological need to have nicotine in their body. And how we do that is we deliver lower doses of clean nicotine into their body. So we want them to quit using their tobacco products, if that's spit tobacco, if that's a cigarette, a cigar, electronic cigarette, whatever they're using. And now they're getting just nicotine from either the nicotine patch, nicotine gum, or the nicotine lozenges. There's not the 69 different carcinogens that are found in tobacco smoke and the 15 or 20, I forget exactly how many carcinogens are in spit tobacco, but we're getting rid of all the harmful stuff. And that's what hurts people and kills people. It's all the other stuff that are in the tobacco products that make people sick and kill them. Nicotine is the addictive drug that makes it so incredibly hard to quit using the products. Nicotine doesn't cause heart attacks. It doesn't cause cancer. It's just the addictive drug that we're trying to get people to step down from. So as we're talking with people about nicotine replacement therapy, the important thing to figure out is what dose should they use of the specific product. And so what we want to see happen is that we want to match the nicotine amounts that they're getting from their nicotine replacement therapy with the amount of nicotine that they're getting from their tobacco products. And so that kind of depends on what products they're using and things like that. But if someone's smoking a combustible cigarette, for pretty much every brand across the board, if they smoke a cigarette all the way through, they inhale about 1 milligram of nicotine. So then if they're smoking 20 cigarettes a day or a pack of cigarettes, they're getting about 20 milligrams of nicotine into their body. So that's why they made a 21 milligram patch. So that the amount of nicotine they're getting from their 21 milligram patch equals the same amount of nicotine that they're getting from their 20 cigarettes per day. So if someone talks about like the little cigars or cigarillos, they have about the same. They have a little bit more nicotine in them, but not a whole lot. They're pretty standardized as well. Just their packaging is a little bit different. They might be sold in 2 or 3 or 5 cigarillos in a pack. But so you could still have that conversation asking them about how many of those they're smoking, and they'll give you a really good ballpark idea of how much nicotine they're getting into their system. And when we look at spit tobacco, either chew or snooze or snuff, and there's some brand new non-tobacco leaf nicotine products that are out there that come in little pouches, you know, that you might see advertised in convenience stores. It's going to take a little bit of trial and error because of the differing nicotine concentrations in these products. The amount of product that they use, there's really no standardized amount that they use, and how long they keep them in their mouth. So all those 3 factors, it's gonna really vary. So I would probably start someone out on maybe a 21 milligram patch, and then see if they're having some cravings or withdrawal symptoms, and up the dose from that point. One thing with spit tobacco, if they're using a can, like spit tobacco from a can or from a pouch, people will typically a typical use pattern, they go through about 1 can or a tin every 2 days, or they might go through a pouch every 2 days, something like that. So that's a pretty standard rate. If someone's going through a pouch or a can a day, they're a pretty heavy user if they're going through maybe a can or a pouch every 3 days or every 4 days. You know, it's a little bit less nicotine that they're getting into their body. But it's going to really have to be very, very individualized for spit tobacco users on how much nicotine they get. And so real quick, I'm going to show you what a nicotine patch looks like. And
Bryce,
yes.
before you move on, what kind of symptoms do they have just going from the cigarettes to the NRT patches or gum? Do they still experience anxiety, or is there any evidence-based data on that, or does it relieve the most of their symptoms?
If they're using a strong enough dose of the nicotine, more than likely it's not going to eliminate everything. Even if they are using a strong enough dose, or maybe even getting a little more nicotine than they were getting from their tobacco product, I'm sure some people are still going to feel a little bit of anxiety, a little bit of stress. You know, one thing that I always caution folks about is that nicotine replacement therapy, it's not a silver bullet. You know, it's not going to make everything perfect. It's not going to make everything really smooth. Really, the only thing that the NRT is doing is alleviating some of those withdrawal symptoms. A lot of that anxiety, some of that stress, that comes from environmental factors of how do they deal with a trigger? How do they deal with people around them? How do they deal with the situation that they're finding themselves in? It's that environmental trigger and that situation that's more than likely going to raise their anxiety, or maybe make them feel a little bit frustrated or angry, you know, something like that. It's more than likely, you know, it's not because of the NRT or going through withdrawals or something like that. But now if someone, for example, if they're smoking a pack of cigarettes and we give them, let's say, a 7 milligram patch, and they're not getting nearly enough nicotine in their body, or even a 14 milligram patch, and they start going through some mild or kind of severe nicotine withdrawals, I think we could relate that directly back to not having enough nicotine from the nicotine replacement. That's a lot of times that's what happens, is that people, they don't use a strong enough dose of a nicotine replacement therapy, And that's the number one reason why they relapse. It's just because they didn't get enough nicotine. And they say, I used it, but it didn't help me at all. I still had these really strong cravings and urges to smoke. That's a clear indication that they didn't use a strong enough dose. You know, they said, I just felt really anxious when I was using the NRT or when I was using the patch or when I was chewing the gum. They probably weren't getting a high enough dose. But if they do get a strong enough dose and they're still experiencing some of that stuff, you know, it might be the environmental situations and just kind of, those are some times where I would really want them to talk to their case manager, their rehab specialist, or whoever's helping them quit to kind of develop a behavioral plan of, well, how can you deal with that anxiety? How can you deal with those situations? Deep breathing exercises, guided imagery, you know, different things like that, you know, which we would do if someone's having a panic attack or an anxiety attack, you know, just having them take those really, really deep calming breaths and to kind of calm their body down a little bit.
Okay, thank you.
Yeah, yeah. And so I'm going to open up some of these box of nicotine gum here so everyone will get a sense of what nicotine gum looks like as well. So now we'll go through these. I'm going to just skip forward. Okay, there we go. I just want to look at a couple of the slides here. So now we'll talk about these products individually and some how to use them, what they look like, and different things like that. So nicotine patches, real quick. They come in 3 different doses. They come in a box that looks like this. There's 14 patches in a box. So one box will last a person for 2 weeks. And so like I was saying, the 21 milligram patch, you'd want to use that for someone who's smoking about a pack of cigarettes a day. And then a 14 milligram patch, you know, if someone's smoking right around 10 to 12 cigarettes a day, probably want to have them use a 14 milligram patch. And, you know, anywhere below 10 cigarettes a day, they could use a 7 milligram patch to help them quit smoking. If someone's smoking more than a pack a day, so if they're smoking a pack and a half a day or 30 cigarettes a day, so they're getting about 30 milligrams of nicotine into their body. So they could use a 21 milligram patch and a 14 milligram patch. You add those up, they're getting about 35 milligrams of nicotine from those 2 patches. And it's perfectly okay if you go over a little bit. I would much rather go over by a couple milligrams than be under. So if someone's smoking 30 cigarettes a day and, you know, they use a 21 milligram patch and a 7 milligram patch, you know, it's not much, but they're just getting a couple milligrams under. And I would just rather err on the side of giving them a little bit too much nicotine. It's perfectly safe and okay. They're not going to overdose from that or get dizzy, anything. They're going to be perfectly fine if you go over by just a little bit. What we wouldn't want to do is have them use 2 21 milligram patches at the same time. That's giving them a little bit too much nicotine at that point. They might get a little bit dizzy, a little nauseous, may have a little bit of an upset stomach. But other than that, they're going to be fine. They're just not going to like that. So that's what happens if they do get too much nicotine in their body. So with the nicotine patches, use 1 patch a day. Each patch works for 24 hours, so it's good for a full 24 hours. Kind of the nice thing about the patches is you don't have to worry about running out of them, losing them, forgetting them somewhere, things like that. Just put it on in the morning and kind of forget about it throughout the rest of the day. And it gives people a steady dose of nicotine throughout that 24 hours. The nice thing about them, they're private. You can put them on any part of your body, cover them up with clothes so people don't even know that you're using them. And like I said, they're once a day. As far as adverse reactions to these, a skin reaction, some people experience a rash from the patches and they'll turn red. It might swell up a little bit and kind of burn or itch really bad. So if someone experiences that, they'll have to take the patch off no matter where they put it on their body. They're going to experience the same thing. And some other folks, they experience were sleep disturbances, very colorful, realistic, vivid dreams. And this doesn't happen to everybody, and not everybody doesn't like these dreams. Some people enjoy those dreams. But if they don't like the dreams, or if they wake up because they had the dreams, more than likely they might not be able to go back to sleep. So if they have the dreams and they don't like it, all they have to do is take the patch off a couple hours before they go to bed, and they won't experience those dreams. So pretty easy way to get rid of those dreams. So this is what the nicotine patch looks like. I'm gonna try to see if I can maybe put it behind this a little bit. That's still not gonna work very well. I can't get it to show up. But this is what the nicotine patch looks like. I'm sorry, it's not coming through very well. I'm gonna change my background real quick, see if I can change my background. If I can figure out how to do that. I can't. So, but anyway, so nicotine patch, it's a clear patch. At least the Nicoderm ones are clear. Some of the generic brand ones are gonna be, look like a latex Band-Aid. They might be round or rectangle, something like that. So that's what the patch looks like. Just peel it on around the edges here. There's little wings right here that kind of peel back. And the adhesive is around the edge of the patch. And you can put the patch on any hairless part of your body. Maybe we'll see if I can get this to show up a little bit better here. There we go. And so you can put it on any hairless part of your body, on your shoulder, something like that, and just leave it there. You want to make sure that it's clean, that it's not oily, it's not wet. Get a really good seal on it, and then it should be able to stay on your body for 24 hours. You probably don't want to take a shower or bathe with it on. It may come off if you do that. So you want to kind of put these on around your bathing or showering schedule. If you shower in the morning, put it on right after you get out of the shower and dry off. Some people might put it on at nighttime and then just do it right before they go to bed each and every night. So that's a nicotine patches. And how to use the patches. And what we want people to do as far as stepping down off of these products. So if I'm smoking a pack of cigarettes a day, I'll start using a 21 milligram patch. I'm gonna use that for 4 to 6 weeks. And then I step down to a 14 milligram patch. I use that patch for 4 to 6 weeks. And then I step down to 7 milligram patch, and I might use that for 2 to 4, maybe up to 6 weeks. And then I stop using the nicotine patch. So just slowly stepping ourselves down off of the patches.
Bryce, this is Kat.
Mm-hmm.
Quick question. So I know we are training and educating our staff. Now, as trainers, and this may be a center specific question, we are trainers, but like Shelly and I, Jacob, we are not clinicians in any way, or Shelly is, excuse me, Jacob and I are not clinicians in any way with any kind of prescribing power or any of that. So say we do the training, we have 5 staff that come to us and say, yes, we want NRTs. Would our next step then as trainers be to advise them to see their medical professional? Or, because I don't know that I would feel comfortable to go, okay, I know how to do math, 21 plus 7 gives me that amount. Is that something that we would do as a trainer and an educator, is to decide the amount of patches?
I think we could give them some advisement, give them the general parameters of it, and saying, you know, based on what you told me or what's going on, you know, how much you're smoking, this is what you could use, you know, and then you could refer them to the instructions in the box. You know, you could advise them to go to their primary care provider, you know, but I think you could give them a basic idea of what they may want to use, you know, and then ultimately it's up to them on what they want to, what they'd want to do. But I think that's where we want to feel comfortable and competent in the information that we're giving them is accurate. You know, first and foremost, I don't think we want to make sure what we're telling them is clinically appropriate. So we wouldn't want to say to someone, if they're smoking a pack of cigarettes, like, oh, well, no, really what you want to do is use a 7 milligram patch. And if we're training someone, that's not good advice. That's not clinically appropriate. So whatever we tell them to do, it needs to be, or whatever we encourage them to do or educate them on, it needs to be clinically supported, I guess, if you want to call it, if you want to say it like that.
Okay, thank you.
And I was just gonna butt in for a second. We have each of the clinics has their case managers will screen when they come in to see if they are if they're smokers and offer that to them. Also during NEO, we do a kind of a short, this will change now, of course, training on it and offer the NRT. But there is at the clinic here in Big Spring, we have a lady who gives them the patches. They don't have to have a doctor's order for it, and it is based off of how much they smoke. So, if they smoke less than, the instructions are on the packages also, but if they smoke, less than a half a pack a day or 1 pack a day, then it'll be a certain number of milligrams. And Valerie Hart here in our clinic, she'll in Big Spring, she is the one that kind of comes up with that dosing, just based off of what they say on how much they smoke. So
Thank you for that. Yeah, I was a little concerned. Thanks.
yeah.
Now, I feel, Bryce, I feel very comfortable with the trainers once we're trained and we're training people using these recommendations. Because there's a need to get out so people know how to use them appropriately. And if they're matching up with, these are over the counter and they're matching up with what the boxes contain as well, I think we do a disservice if we don't do that, because someone that isn't got this information might just assume, well, I'm going to start you on the 7 milligram, or I recommend the 7 milligram when they're smoking a pack and a half a day, and you're setting them up for failure doing that.
Right.
So I'm comfortable if we give the recommendations out to them.
Yeah.
And we'd certainly want, like Natalie was saying, Valerie to be doing the same thing with people.
And maybe in your training, and Natalie, I'm really, I'm happy to hear that you kind of have those guidelines, and maybe in the training at West Texas Center, you share those guidelines as part of your training. You say, this is based on, the information that Valerie has, this, if someone is smoking this number of cigarettes, and that it's just really spelled out pretty concrete in a very concise way, that so everybody understands that and they know kind of what that expectation is, and so that you don't have, Bryce saying, oh, no, you only have to use a 7 milligram patch, and then you have Natalie saying, well, no, you need to use a 21 milligram patch, and that there's not this wide range and discrepancy, and that everybody knows based on the training, this is what people will get. Under most circumstances, and there's going to always be a kind of a gray area, or someone might not be comfortable. The client might say, well, I've used a 21 milligram patch, but I didn't think that really was what I needed. I felt like I needed something more. And so, there's always going to be some of those kind of gray area cases, and where you're going to make an exception to the rule. But for the most part, we should stick to that rule or to those guidelines.
Definitely.
Yeah.
Bryce, can I ask you one question before you start again?
Mm-hmm.
On the patches, I heard you say the 21 milligram patch for 4 to 6 weeks and then drop to the 14 milligram in another 4 weeks, or when you finish that. When did you say you dropped to the 7 milligram patch?
So you drop down to the 7 milligram patch about 4 to 6 weeks after you start the 14 milligram patches.
Okay.
So,
Okay.
And if you
And
look,
then when do they go off totally after they're on the 7 milligram?
I would, that one is very individual, because at that point, some people feel really confident. Some people might only use the 7 milligram patch for 2 weeks. Some might use it for 4 weeks. Some people might use it for 6 weeks. So I always say about 4 to 6 weeks you know, for all three of them, just kind of, you know, if you look on the box, the boxes give a little bit different strategy. So I'm just looking at the 21 milligram box right here, and it says step 1. So you'd use the 21 milligram patch for weeks 1 to 6, you know. So they say use it for a solid 6 weeks. And then step 2, which would be stepping down to the 14 milligram patch, weeks 7 and 8. And then week 3, which would be the 7 milligram, week 9 and 10. And so that's on the box. But when I say kind of that 4 to 6 weeks, that's kind of what we see people doing, you know. I think, and that the people that we're serving are a little bit more highly dependent on tobacco. They've tried a lot of other things, and they've tried to quit in the past. And I think it takes a little bit longer for the people that we're serving than kind of what their clinical trials with general population, you know, just a wide range of folks. So what I recommend is a little bit different than what it says on the patches, you know, but that's, if someone uses what's on the box as a guide, that's perfectly okay to do as well. But, you know, kind of what I, you know, when I train folks, it's more of that, this is what we see in the real world type of a step down process, about 4 to 6 weeks on 21 milligram patch, 4 to 6 weeks on the 14, and then 4 to 6 with the 7 milligram. It just takes our folks a little bit longer to successfully quit smoking. Yeah. So, well, very good. Well, wonderful. Very, very good questions, everybody. Perfect. So now to look at the nicotine gum and the nicotine lozenges. So the nicotine gum, they come in a box that look like this. Let me see if I can get this up there. So, oh my gosh, my webcam and my background isn't looking very good at all here. There we go. So a box, there's 100 pieces in each box. And then for the lozenges, they come in, one box has 3 of these little vials like this. And there's 27 lozenges in each vial. They have a little safety lid on it here. You got to kind of click on it and then open up, and then the lozenges are in there. So I'll start out, I'll show you what the nicotine gum looks like once you open it up. So once you open it up, they'll come in a little blister pack like this. There's 10 pieces in each blister pack, you know, and you just pop them out the back. They'll have the dosage on them. So I don't know if you can see that here. They'll have like a little N4 or an N2 on there. So these are 4 milligram gums. So nicotine, you know, 4 milligram. If it was a 2 milligram, it'd say N2 on there. So that's how you kind of know. It's also on the back of the package. It also tells what flavor it is on the back of the blister, along with an expiration date on each of the blisters. And then it's also on the box as well. So for the nicotine gum, we'll just pull one out here real quick. Should have had all these out and ready to go. There we go. Peel it back and just pop it out. And then that's what the gum looks like. It looks like kind of like a chiclet kind of gum. And so the nicotine gum, folks want to use, well, both the gum and the lozenges. I'll show you what lozenge looks like. These are little mini lozenges. And to kind of put it in comparison to like an eraser on a pencil. Move it over here. There we go. So very small, about the size of a Tic Tac. You know, to kind of put it in perspective of, these are the mini lozenges, and they also do make a bigger lozenge, which is about the size of a like after dinner peppermint, you know, something like that, those bigger peppermints. But I think for the most part, a lot of folks are transitioning to the mini lozenges just because they dissolve quicker, they're easier to use, things like that. So they also come in 2 and 4 milligram doses. So that's what the products look like. Those 2 things right there, kind of put them in next to each other a little bit. So the use pattern for these products is very individual, which is kind of one of the nice things about these products is it's not a real standardized use pattern. It's kind of however often people get a craving for a cigarette or kind of a craving for nicotine. But on average, people use one piece every 1 to 2 hours. Some people might use them every 45 minutes. Some people might use them every 2.5 hours or something in between there. They might use one, once every hour, and then they don't use one for 2 hours, so very, very individual, which is kind of a nice thing about these products. The other really nice thing about the lozenges and the gum is it offsets cravings really quickly. They get nicotine into their body relatively fast. Within about 5 minutes, they get a good dose of nicotine into their blood with both the lozenges and the gum. The lozenges absorb a little bit quicker than the gum, so if someone's having a strong craving, they could pop one of these in and chew it or suck on them, and it'll take the edge off of that craving really, really quickly. It also helps reduce the dependence by just lowering those urges, those cravings, eliminating the withdrawal effects of things like that. So so that's a little bit of information about the gum and the lozenges. So how to use these products, and they kind of lead to the adverse effects. So with the nicotine gum, obviously you chew it. It looks a lot like a piece of gum. It kind of tastes like a piece of chewing gum, but we don't want people to chew it like a regular chewing gum and just keep chewing it. What we want them to do is put it in their mouth and chew it up about 10 times or so until they get this peppery taste. That peppery taste is the nicotine being separated from the gum. Once they get that peppery taste, what we want them to do is to put it, I'm just going to put it in my mouth without chewing it, but put it right between their cheek and gum, almost like they have a dip in their mouth. And just let it sit there. It's going to tingle. And once it stops tingling, they want to move it out of there, move it and park it on the other side and let it sit there. And wait, it's going to start to tingle. Wait till it stops tingling. And that's going to maybe take about 5 minutes before it stops tingling. And then we want them to move it again and then park it on the other side, wait for it to stop tingling, and keep moving it. And every time they move it, they want to just chew it up a little bit to release a little bit more nicotine out of the gum. Get that out of my mouth so I can talk normal now. And so after maybe about 20 or 25 minutes, or when it stops tingling, that's how they know that that all the nicotine, or the majority of the nicotine, has been absorbed out of the gum into their blood. And so that's what we call the chew and park method. So it's very important that they use it in that manner. If they put this piece of gum in their mouth and they just chew it and chew it and chew it and they never park it, what happens is they separate all that nicotine from the gum, and then it gets mixed in with their saliva, and then they swallow it. And that's where they get the hiccups, the indigestion, the heartburn, different things like that. So it's really important and then on top of that, the nicotine never gets absorbed into their blood, and so then they go through nicotine withdrawals. And so if someone says, I used the gum, but it didn't help at all, it gave me a stomach ache, and I had really strong cravings, it's because they used it wrong. The other thing is the gum, it's a little bit harder. It's not as hard as it used to be, but it's harder than regular chewing gum. And so if someone's chewing 8 or 10, maybe 12 pieces of the gum a day, you can imagine that their jaw might get a little bit tired or sore from chewing the gum throughout the day. So that's the other thing with that. But aside from those things and hiccups, even if people use these products properly, more than likely they're going to get hiccups, and kind of bad hiccups as well. It's one of the really kind of unfortunate side effects of the medication, just really annoying bad hiccups. So that's a nicotine gum on how to use it properly. And then the nicotine lozenges, like I said right here, these are very easy to use. So all you do is put it in your mouth and then let it sit there. Put it between your cheek and gum. You don't have to move this around. A person can, but just let it sit there in between their cheek and gum. And as it dissolves, the nicotine is absorbed into their blood. It'll take about 8 to 10 minutes for this to dissolve, maybe up to 12 minutes. So very, very easy to use. It's, you know, you can kind of tell I have something in there, but I can still talk now that I have it in my mouth. But, and that one, yeah, for the lozenge, I could really feel that tingling in my cheek there. I couldn't really feel it with the gum because I didn't chew the gum up, but with the lozenge, I could really feel it just starting to dissolve in my cheek and gum there. So it works really, really quickly. We don't want people to chew them up. We don't want them to swallow them whole. If they do that, they're not going to work effectively, and they're going to get an upset stomach and indigestion, possibly heartburn also with that. Insomnia, I'm not really sure why the insomnia is listed. I've never heard or had anyone experience state that they've felt that they haven't been able to go to sleep or get back to sleep because of using the gum or the lozenges. So, but it's on the box. It's a side effect that's listed, but I've never ever had anyone say they've experienced insomnia from using that. So real quick, any questions about the gum or the lozenges? Anything that you might have? All right. So the next one, I don't have any samples to show you what Chantix looks like, or Wellbutrin or Zyban, but these two products here, they're non-nicotine products. So there's no nicotine in Chantix, there's no nicotine in Wellbutrin or Zyban, and it comes in a pill form, and you need a prescription for both of these products. So Chantix to start out with. Chantix is the most effective tobacco treatment medication we have. About 44% of people who use it and are getting some help from a counselor, a call Quitline, something like that, successfully quit smoking. So it works very, very well for people who can tolerate it. So by far and away the most effective. So the regimen for both Chantix and Wellbutrin is 3 months. So they would want to use these products for 3 months. And with Chantix, the first month that they get the box, it's called a starter kit. And it's because they have a 0.5 milligram tablet in the starter kit. And so what they do is they use a 0.5 milligram tablet for days 1 through 3, once in the morning. And then from days 4 through 7, they use a 0.5 milligram tablet twice a day, once in the morning, once in the evening. And then starting on day 8, through the course of treatment, they'll use a 1 milligram tablet once in the morning and once in the evening. So very, very easy to use. And just drink a full glass of water and eat a little bit of a snack while they take this medication. And by drinking a full glass of water and eating that little bit of snack, it tends to get rid of that nauseous feeling that some people experience. And so a lot of people, they do feel this nauseous feeling, but drink that water and have a little bit of food with it, gets rid of that. Probably the second most common side effect that people experience are abnormal, strange, very vivid, possibly very trippy dreams. And not a lot of people tolerate these dreams. They don't really like these dreams. Unlike the nicotine dreams, where some people kind of like them, these people just, a lot of people don't like them at all. And unfortunately, the only way to get rid of the dreams is to stop taking the medication. One good thing about Chantix is you can stop taking it. You don't have to worry about weaning off of it, or having withdrawals or side effects of stopping taking it. Just stop taking it. Those dreams will go away, and any other negative side effects that people may be experiencing because of the medication will also go away. So some other side effects that we'd want to be aware of and just to have in the back of our mind is that some people, when they use it, they've reported to experience depressed mood, agitation, change in behavior, suicidal ideation, things like that. And so obviously it seemed like some pretty big red flags for people who might have a mental health disorder. But what research is showing is that people are pretty stable if they're managing their mental health, if they're taking their medication on a regular basis, and they're pretty stable in their recovery. Then they use Chantix. They don't really see a significant increase in any of these risk factors than people without a mental health disorder. So it's pretty well tolerated for people. that are stable in their recovery. Obviously, if we have someone who's clinically depressed or majorly depressed right now, or someone who's had thoughts of suicide in the recent past or has attempted suicide in the recent past, we wouldn't want to prescribe this or even encourage someone to use this medication. But for the most part, if someone's doing pretty well in their recovery, they may be able to use this medication with very few side effects. And so that's a little bit of information about Chantix.
Bri,
Yes.
let me ask you a question, because I know that we had an individual, happened to be a physician, that was on Chantix and was really, really making him nauseated and throwing up. And does that tend to be a rare occurrence, or do you think that most people are able to tolerate that as long as they take it with a full glass of water and a little bit of food?
Yeah, and I've helped probably 40 or 50 people quit smoking or try to quit smoking using Chantix. It's not a huge sample size, but I've never heard of anyone vomiting or getting like that sick from it. Not saying that it's not possible, but I've never personally had anyone. But I have had some people where they just feel like their stomach is upset, you know, and then we discontinue it if it would continue. But a lot of folks, it just like they just have a stomach ache, you know, and then if they drink a full glass of water and eat some food with it, it seems to take care of it. But yeah, that was a pretty extreme reaction. You know, I've never heard of that, and I've never seen it myself, but I'm not going to discount it that wasn't that physician's experience with that. Yeah, and it's just one of those things that, which once again, you know, stressing that follow-up, that if someone uses a medication or uses something, even if they use a nicotine patch or they use a nicotine gum and they get a really, really bad stomach ache from using it, we want them to come in and let us know what's going on with them. And so that follow-up is probably the one that we don't do, that we do the least of as far as the 5As, but it's probably one of the most important actions of the 5As is following up with people, arranging that follow-up and tracking them and seeing how they're doing and how they're tolerating all these medications. Yeah. So Wellbutrin, you know, I think we all know that it's an antidepressant medication. It comes in a tablet of 150 milligram tablet. People use it 2 times a day. Once again, that's a 3-month regimen that they can use that medication. Dry mouth, insomnia are 2 of the main side effects from that. And we wouldn't want to use this medication with someone who has a seizure disorder, an eating disorder, or any type of a behavior that might put them at risk of having a seizure, like if they're addicted to alcohol or some other barbiturate or something like that, where if they stop using that product, that they might go into seizures due to withdrawal symptoms, things like that. And one thing with Wellbutrin is if we combine Wellbutrin and Zyban is like the brand name for the smoking cessation. It's the exact same medication. But if you combine Wellbutrin with a nicotine replacement therapy, that works really well. It gives people about a 36% chance of quitting smoking, which that combination therapy is kind of the second most effective way to help someone quit smoking. So any questions about Wellbutrin? All right. The other thing with the nicotine patch, the gum and the lozenges, I didn't know if we had a slide on this. We might a little bit later, but it's perfectly okay. And we actually encourage people to use, you know, if they want to use a nicotine patch, they can also use the nicotine gum or the nicotine lozenge at the same time. So maybe they put on a patch and they have some high stress, high craving times during a day. Maybe driving their car to work is really a trigger time for them. They put on a patch in the morning, and then as they're driving to work, they could chew a piece of gum, maybe right around lunchtime. they could chew a piece of gum. On their drive home, they could chew a piece of gum or suck on a lozenge, just to give them a little bit extra dose of nicotine to kind of get them through some of those times. Maybe they're going out with friends and they know that some people are going to be smoking and they just want a little bit more nicotine to help offset some of those urges or craving that they might experience. That's perfectly okay. It's perfectly safe to do that. That's considered a best practice to do that combination therapy with the patches, the gum, or the lozenges. Just as long as someone's not chewing, putting on a 21 milligram patch and chewing 10 pieces of gum a day, something like that, then they'd be getting kind of a double dose of nicotine. But if they're using 2, 3, or 4 pieces of gum throughout the day or lozenges throughout the day, that's perfectly okay. This is a cost comparison. I'm not going to go through this, but it's actually cheaper to buy nicotine replacement therapy for a month than it is to buy a pack of cigarettes for 2 weeks. So sometimes people say, well, it's way more expensive to buy NRT. Although it's not cheap, it's significantly cheaper than smoking cigarettes, a pack of cigarettes a day. And especially if people buy the generic brands, it's significantly cheaper than buying kind of the name brand, the Nicoderm or the Nicorette products as well. And they also do have them in smaller doses, so you don't have to buy a box of 100 or 120 pieces of gum or lozenges. You can buy 10 or 20 pieces. They even have packages of 5 and 7 milligram or 5 and 7 patches now. So you can get them in much lower quantities and save some money. This is a quick summary of which products are over-the-counter medications, which ones are prescription, the inhaler and nasal spray, which we didn't talk about here, but we talked about in the big training. You need a prescription for those. So we have 3 over-the-counter medications and 4 prescription medications. One thing that we also like to talk about are some of the challenges with psychotropic medications that people may be taking and how they interact with tobacco and tobacco smoke. And some of the medications, it might make people feel lethargic or they gain weight, they can't concentrate, they might not be able to sleep very well, they might feel nervous or anxious when they're on these medications. And maybe they started using these medications in early adolescence or maybe in their 20s or something like that, and they started to smoke because they heard that smoking a cigarette gives them a boost of energy because of the nicotine to offset some of those lethargic feelings. And anyone who smokes or uses a tobacco product gets that boost of energy. Nicotine does have mild appetite suppressant properties, so it doesn't stop people from being hungry, but it does take the edge off of hunger pangs. And so maybe if someone's limiting their food intake and they're hungry, they might start smoking or using more tobacco products to kind of reduce that hunger that they're experiencing to offset their weight gain. Nicotine does help people focus, and it does improve our concentration and memory to a certain extent for a little bit. So you might see how people are using that to kind of offset or compensate for some of their mental health concerns as well. And it does provide a sense of relaxation and well-being, especially if someone is going through nicotine withdrawals. And this is where we kind of can change that paradigm, or maybe get people to look at what's going on when they smoke a cigarette and they experience this sense of relaxation or reduction in stress. Is maybe someone hasn't had a cigarette for 2 hours or 2.5 hours and they're feeling really anxious, and their body is starting to get stressed out because they're going through nicotine withdrawals and they're experiencing some pretty severe nicotine withdrawals. But then they smoke a cigarette, and that anxiety and that stress just kind of leaves them magically, right? And they think that they're actually experiencing true anxiety, right? Or they're experiencing this stress, which they are, but it's a nicotine withdrawal induced stress instead of being really anxiety. So if we can talk to people about that, what's going on, and bringing a little bit of awareness of when they smoke a cigarette and when they don't, and what happens when they do smoke a cigarette, they might start to connect some of those dots that it's actually their smoking and their nicotine withdrawals that are causing that anxiety, and that smoking isn't really solving their anxiety. And talking to them about how nicotine replacement therapy can get rid of that and get them off that roller coaster of experiencing anxiety and stress and smoking cigarettes to do that. So But as we're talking, the other thing, when we're talking to people about quitting smoking, it's important that we do acknowledge some of these quote unquote benefits that they're getting from their tobacco use. Because if we don't talk about the kind of the benefits or the good things they're getting from their tobacco use, we're missing a big piece of that puzzle in helping them quit. Because we're going to have to identify ways to deal with that lethargic feeling, you know, if that's exercise or eating healthy foods, you know, hopefully drinking 10 Red Bulls a day isn't a way to deal with that lethargic feeling and getting caffeine in their body. But how are we going to help them kind of get some of that energy back in their body? Eating fruits and vegetables, something like that, the natural sugars. How are we going to help them deal with weight gain or offset weight gain, some stuff like that? How can we help them develop healthy coping mechanisms and ways to deal with stress and anxieties throughout their day without turning to a cigarette? And so we do have to talk to them about all these things. And even though there are some quote unquote benefits, it doesn't justify us not helping them quit or not helping them quit using tobacco products. So just some things to think about with that.
Bryce,
Yes,
can you go back to that slide?
absolutely.
On the help focus, improve concentration, is that just when they're smoking, they feel like it helps the focus and the concentration?
Mm-hmm.
It's just an effect right when they're smoking.
Yes.
Is that correct?
And then it tends to diminish. And that's, you know, one thing that when we look at the smoking patterns of people with schizophrenia, specific, you know, when we really look at, or if someone's in a manic episode with bipolar disorder where they might just chain smoke cigarettes, you know, it might be helping them focus, might be helping them concentrate. And especially with people with schizophrenia, we do see that it does have that kind of, not really improving their concentration, but what it helps is kind of focus their mind a little bit, kind of help slow their mind down a little bit. You know, my mentor, when I was working at a counseling center at a state university, he told me a story of that when he was going through his psychiatry residency. He was working at the state hospital in South Dakota, and at that hospital, they actually had built-in cigarette burners into the walls, and where you'd push a button and then the coils would heat up, like back in the day when we had the cigarette coils in cars, you know, and you'd push it in and then it'd pop out and you'd light your cigarette with the coils in a cigarette lighter in a car. And they had those built in all throughout the state hospital in South Dakota. It was in Spearfish, South Dakota, is where the state hospital is. And so people would just carry their cigarettes with them, and then they would push the buttons and then smoke cigarettes right there in the hospital. And he said that was one way that they helped kind of medicate people with schizophrenia. And thought that was that was one of the main treatments, was just to have them smoke as many cigarettes as they could. And they made it, you know, they didn't want them to have matches and cigarettes, so they installed all these little burners all throughout the hospital. And there is some truth to that, you know, and that's the thing with a lot of these myths or beliefs. There is a grain of truth to all of them, and that nicotine does have positive impacts on people to a certain extent.
So do the NRTs give them any of those?
Absolutely. And that is
Okay.
absolutely correct. That's absolutely correct. And so NRT, it does give them a little bit of boost. But one of the nice things about the NRT is it gives them this boost, but it's in the nicotine gives them kind of like the energy boost. It does help with appetite suppressant properties a little bit. Well, actually, even Wellbutrin does too. Wellbutrin works pretty well with helping people kind of manage their weight. Of all the medications, Wellbutrin works pretty well with helping people manage their weight gain and hunger, actually. But nicotine replacement therapy, yeah, but it doesn't give them a real sharp, a really high boost of energy, stimulant effects of nicotine is a stimulant drug. And so that's something else you might want to talk about during the training, that it is a stimulant drug. And so it does give everybody that boost of energy. But it's not as intense as if someone smokes a cigarette or is using spit tobacco or using electronic cigarette. It's a lower dose of nicotine, and it's kind of dissipated over time, you know, for all of them, the patch, the gum, or the lozenges. And so they're not going to get the same boost, but they are going to get a little bit of a boost of energy. It does help with that focus and in improving the concentration and memory and all that kind of stuff. And it probably even works better for people using nicotine replacement therapy than a cigarette, because you have that big spike. And if you remember back from the training a couple of weeks ago, where you get a big spike with cigarettes and then the nicotine withdrawal relatively quickly. With the NRT, it lasts a little bit longer, and then the withdrawals are more gradual. So I would even say, and I don't have any research or study to prove this or to support this, but I would think that NRT would probably even help a little bit better with that focus, just because they get nicotine in their body for a longer period of time. And then with that stress and relaxation, they just kind of eliminate that feeling. You know, we get rid of the withdrawals, we get rid of that anxiety, and we kind of keep people at a level stage, rather than going through this roller coaster of getting hits of nicotine and then withdrawing from nicotine. So yeah, nicotine replacement therapy works. And actually, I was doing a training up in Abilene early on, and a lady up in Abilene at Betty Hardwick Center, she said, so if I want to go on a diet, I should use a 21 milligram patch, you know? And like, well, you probably could, you know, if you wanted to maybe limit your food intake, but it's not the best way to go on a diet. So I said, no, that's not the best way to go on a diet. But in reality, it probably would work, you know, if someone wanted to do that, but obviously we don't want to recommend that. And
Okay, thank you.
yeah, you're very welcome. Very, very good questions. Thank you for asking some of those. So this is a slide about the electronic cigarettes, and just to kind of explain this. So over here on the very far left side is kind of what a combustible cigarette looks like in size and shape. And our first generation, which what we call the Cig-a-lites, were very similar in size and shape. They were a little bit bigger, longer, and a little bit fatter, but they you know, had a little glow tip that would turn blue or red or whatever colored, kind of simulate the cherry that was on a combustible cigarette. You know, these didn't have a very powerful battery. They didn't have a lot of nicotine juice in them, so they weren't very, very satisfying to use. They didn't deliver a very good punch of nicotine, you know, and so people really didn't like these very, very much. So then the second generation is what we call a tank system. And so you have a little tank here, and you fill this clear area up right there with the nicotine juice. And then they added a larger battery on the end of these. So you got a little bit better hit. It held more nicotine juice in there. And then the next generation, third generation, now they have two batteries in them, a bigger tank to put more juice in it. And you can adjust the voltage, and that's with the little plus and minus sign there. So you can heat up the coils more, deliver a little more electricity to heat the coils up. The hotter the coils get, the more aerosol and more vaporized the nicotine is going to be. And and I don't know the word, I'll use vaporized. It's not the right word, but I know that aerosolized is probably even a word, so I'll say vaporized. The more vaporized you get the nicotine, the more hit you get, and the quicker it gets into people's lungs. So the more power you have, the hotter your coils will get, the quicker it's going to be absorbed into your lungs. So that's what made these, and these are called mods, because a lot of these products, they can be like a mod tank system is kind of the language for these. And because they can be modified in a lot of different ways. So they're pretty effective. They give a pretty good kick, but they're big, they're expensive. They take a long time for the batteries to charge. And so that's kind of some of the downfalls. They're heavy, you know, they're kind of messy also. So that's kind of the downfall to the mods, even though they work really well. And then the latest generation, which are the Jewels and the Blues and all these kind of things, are very small pods. These are rechargeable by plugging them into a USB port on a computer or in a car or something like that. And each of these little pods that are in this picture, they have the equivalent of a pack of cigarettes as far as nicotine concentration. So they pack a real wallop for a very, very small product. Very efficient way to get nicotine into our body. Very similar to a combustible cigarette, probably the closest thing we have as far as electronic nicotine delivery system of getting nicotine into our body, comparable to a cigarette. Not quite like a cigarette, but they're getting very, very close. So the evidence suggests that these are less harmful than a regular cigarette, but they're certainly not harmless. Each and every one of these products, they do have trace levels of carcinogens in them, which are cancer-causing agents, and ultrafine particles, you know, in them. So there's heavy metals that actually come from these products, and that's especially these that use like the heat coils. The metal kind of leaches off of the liquid and gets into the aerosol as well. So they're certainly not harmless, but they're not as harmful as a cigarette, it looks like, so far. One thing, though, that's really problematic about electronic cigarettes is this dual use pattern where people will use a combustible cigarette and electronic cigarette. And a lot of times people start using the electronic cigarette with the best intentions of only using these products on their own, but then they get stuck in this pattern of smoking and using both. And a lot of times they're getting a lot more nicotine than they would be if they're using only one of these products. And plus they're spending twice the amount of money on two different nicotine delivery systems now. They're combustible cigarette and electronic products. So we really want to discourage people from using these products. And if they are using one, just stick to one and not get stuck in this dual use pattern. There's no evidence, or I won't say no evidence, there's very limited evidence showing that these are effective in helping people quit smoking. You know, for the most part, people start using these products and they continue to smoke a cigarette, or they'll transition, completely stop using electronic cigarette and continue to use their combustible cigarette. And we have no idea what the long-term health consequences of these products are. You know, they've been around for 6 to 7 years, going on probably the 8th year of these products. And they're evolving very, very rapidly, the technology. And so we have no idea what one product will do after 20 years or 25 years of using these products. And we know that even short-term, there's changes in the lung lining, and our immune system becomes compromised when using these products. And ultimately, we should discourage people from using electronic cigarettes, and we certainly shouldn't use these products as a first or maybe even a second line as far as a cessation method. You know, if someone's tried to quit smoking for years and years and years, they've tried the patches, gums, and medications and hypnosis or acupuncture, you know, and they're at wit's end and they want to give electronic cigarette a try, I'd say if you want to give it a try, you've tried everything else, it can't hurt to give it a try, you know, but I wouldn't recommend this as a first or second line. So I know we're running kind of short on time here, but real quick, just some of the benefits of a tobacco-free policy, you know, and all your centers are tobacco-free, just reducing secondhand smoke exposure. First and foremost, most important thing with that policy, providing a healthy environment for everyone to come in for services, for everyone to come in and work. It helps reduce smoking rates amongst behavioral health providers. It doesn't impact the willingness for people to come in for treatment. We know that it increases quit attempts, decreases the number of cigarettes smoked per day, increases the effectiveness of medications, all the different things that go on when people have tobacco-free policies and people cut back or quit smoking cigarettes. So to engage people that use tobacco products on your grounds, you know, be polite and respectful, be empathetic and understanding. Just listen to what they have to say. Doesn't need to be a 5-minute conversation, but just hear kind of what's going on, and you know, educate why you have the policy. Let them know the expectations, and just don't be judgmental and criticizing them or blaming them or shaming them, things like that. Just have a very compassionate, you know, respectful conversation with them. I think if we have that attitude, they're going to reciprocate that attitude to us probably 9 out of 10 times. So as far as some resources to help people quit for clients, we can encourage them to call the Texas Quit line. We can refer them from these 2 links. One's from a desktop or from a laptop, you can refer them, or you can download an app on your phone and refer them from a phone. That's the website to download the app. People can use a text message program. Smokefree.gov is one that we really support because it provides specific text message to a number of people that we provide services for. Nicotine Anonymous has some online support groups and telephone support groups that are kind of unique and innovative. Non-smoking AA and NA meetings, the vast majority of meetings are already smoke-free inside. You know, some churches, some other environments, maybe if it's in a school or something like that, maybe even outside of the facilities are smoke-free or tobacco-free as well. And then if your center is providing nicotine replacement therapy to people, that's an additional resource. And then a lot of the same resources are also available for employees. And so with that, I'm going to stop the recording.